Hi, hello, good morning, everyone. Thank you so much for joining this early morning session. So this session is the Raymond F. Sinazi and Family Foundation Scholarship Awards. My name is Till Danjuma. My name hasn't changed, the past president of the World Hepatitis Alliance. So the World Hepatitis Alliance actually looks out for opportunities where we have support to bring more people to attend our meetings. So that's why the Raymond F. Sinazi and Family Foundation Scholarship is a scholarship for those submitting abstracts to the World Hepatitis Summit from low and middle income countries. The RSFF scholarship was given to the 5 of the highest rated qualifying abstracts received and supported awardees to attend the summit in person to give an oral presentation. So it is my honor to have on stage Dr. Raymond Sinazi, and he has a very rich background in HIV, hepatitis B, and hepatitis C. And I will say this sincerely that on behalf of the World Hepatitis Alliance, we thank Dr. Raymond for the support. It added value by supporting the folks that submitted the abstracts to attend this meeting. I'll please, can you give you a round of applause? Let's appreciate Dr. Raymond. So the sponsor biography. Dr. Raymond Sinazi is the Francis and Winsett Walters Professor of Pediatrics, Director of the Division of Laboratory of Biochemical Pharmacology, and a co-director of the HIV Cure Scientific Working Group within the NHI-sponsored Emory University Center for AIDS Research. A world leader in nucleoside chemistry, Dr. Sinazi's work has revolutionized the landscape of antiviral therapy for HIV, hepatitis B, and HCV. The Raymond F. Sinazi and Family Foundation is a private foundation supporting a wide range of causes important to Dr. Sinazi and his family. And so we have on stage Dr. Sinazi, and I'll hand over to him to call the awardees and have a handshake on stage.
Good, but before we do that, I just want to thank the organizers of the World Hepatitis Summit for giving me the opportunity to be here in the beautiful city of Lisbon. And here we have many friends in the audience and friends outside as well. I am very honored to be here and to give out the awards today. I was born in a low to middle income country. I was born in Egypt, so I understand the need for scholarships, and I'm very fortunate to have been successful developing drugs for HIV, hepatitis B, and hepatitis C, and especially for hepatitis C, developing sofosbuvir, a drug that actually cures instead of just providing a Band-Aid. So we're very pleased to be here. My wife, unfortunately, is not here today to give the awards to, but I wanted to just say a few words. And thank you again for inviting me to come and attend this meeting. So we have a few awardees, and I will start with Mohammed Ahmar Khan. While I'm talking, please come up. He's from the Association for Social Development in Islamabad, Pakistan. Congratulations. Congratulations, my pleasure. So if you hold this like this, we'll take a picture. It's a very special gift, especially on Eid. Okay, next one is Thandar Naing. And she, the Clinton Health Access Initiative, Yangon, Myanmar. Congratulations. Never been to Myanmar. Hopefully one day I'll come. Thank you. Pleasure. Thank you. Okay, next one is Bao Vu Gong. He is from Path, Hanoi, Vietnam, another beautiful country. Nice to meet you. Real pleasure. Very much. Okay, Next one is from the very special place, Anna Koperia. She's from National Center for Disease Control and Public Health in Tbilisi, Georgia. It's a very special place because this is a place where basically they're really trying very hard to eliminate hepatitis C, and I was partly involved working with people in Tbilisi, and hopefully one day I'll come and visit you also. Congratulations. Beautiful. My pleasure. Thank you. Okay, last but not least, Robert Kozasi. Okay, here he is. He's from the Clinton Health Access Initiative in Jakarta, Indonesia. We have the real United Nations here. Pleasure. Thank you very much. Thank you.
And a handshake and a photograph with me and Dr. Raymond. Thank you so much, sir.
Pleasure. Thank you.
We hope the world needs more people like him to support hepatitis elimination. And we hope the next summit will have more of such support that will come to bring people around the world to come and really collaborate in eliminating hepatitis. So it was an honor for me to chair this, and I will have the honor now to call on the chairs of the next session, Dr. Fumi, Leshi, and Lian Tran to come up on stage for the next session. Thank you so much, everyone.
Good morning, everyone. Thank you so much for joining us in this session. So my name is Lian Tran. I'm from Australia and originally from Vietnam. So I am a researcher at the WHO Coordinating Center for viral hepatitis at the Doherty Institute in Australia, and also a co-founder and director of Hepatitis B Voices Australia, a community organization wholly led by people living with hepatitis B in Australia. Glad to be here to join the session for triple elimination of mother-to-child transmission. So we think that it is a family business for Hep B, HIV, and syphilis, and that's great that we talk about that today.
Thank you very much. And just before we get started, just to highlight that the purpose of this session is really to explore the roadblocks to hepatitis B PMTCT and how to move from policy to implementation, and what are the strategies to overcome barriers to implementing what we've been talking about for the past 4 or 5 years of PMTCT, and how do we scale up nationwide access? What are the steps that can accelerate action? And before we get started, I just want to show some data on the screen. Can we have the next slide? Just to highlight some of the data that comes out from the hepatitis report. Can we have the next slide? Okay. So from the Global Hepatitis Report, I hope you've all had time to look at the report. And we see the burden of hepatitis B, more than 250 million. And the regional variation of hepatitis B is clear. Can we have the next slide? Now, the next slide is important as it shows that in 2022, there were 1.2 million new hepatitis infections. And as you can see, there is a regional variation. There are new infections in every single region for a start. There's new infections in the Americas, in Southeast Asia, even in the European region and the EMRO and the Western Pacific region. But it is clear that the Africa region has more than 60% of the new hepatitis B infections. I also want to show the number of deaths caused by hepatitis B. One key word I took away is the increasing mortality of hepatitis B. So the question is, how do we stem the transmission of hepatitis B? How do we begin to integrate to reach the 2030 targets? We do know that, yes, we met the 2020 targets globally, except a few regions where the target was not met. So in the next 7 years to 2030, how do we go about it? So we have an excellent panel today of people from Gavi, from UNITAID, to maybe discuss this very exciting topic. We have 2 countries that have taken huge steps in PMTCT, Thailand, Ethiopia, and we also have other partners that are doing great work in this field. And we'll introduce them. I'm going to hand over to Lien to begin the introductions. Thank you.
Thank you very much for me. So I guess the first question that we want to hear from Gavi, Dr. Michael Bisson. So I guess what we heard from Gavi yesterday, I think, warmly welcome Gavi to decide to resume hepatitis B booster dose in country programs. So today I just want to hear from you around what are your reflections on the current status of triple elimination and what has been or is being planned, the unique comparative advantage of your organization in this area, and surely in addition to the happy birth dose that we heard yesterday. We're glad to hear. Thank you.
Thank you, everyone. I would like to start by thanking the organizers of this summit for inviting Gavi to speak about its role in triple elimination, especially in the elimination of hepatitis B, mother-to-child transmission. So I'm Michael Bisson, and I work with Gavi as a program manager for the hepatitis B birth dose program. And regarding the current status of triple elimination and what's Gavi's comparative advantages in this area, generally Gavi is supportive of the global goals of hepatitis B elimination and the triple elimination of mother-to-child transmission of HIV, hepatitis, and syphilis. And specifically, Gavi's specific contributions and unique comparative advantage will be on the elimination of mother-to-child transmission of Hep B through supporting countries to introduce and scale up the hepatitis B birth dose vaccine programs in their schedule. So up till 2022, or since the year 2000 up to 2022, Gavi has been supporting hepatitis B vaccination for the standard series of schedules given at 6, 10, and 14 weeks. It has supported those vaccines through different transitions from the monovalent to the pentavalent to the hexavalent, and now with the the vaccine has known like different transitions because it's given in combination with all the standard vaccines at that age. And between now and then, about 700 million children have benefited from these vaccines, which has contributed to preventing horizontal transmission of hepatitis B. And now Gavi is coming in to support with the introduction of the birth dose, which will be launched in June 2024 this year. And this will greatly contribute to the triple elimination in achieving the triple elimination impact targets of achieving less than 0.1% prevalence in children less than 5 years old. So Gavi support will also help countries to attain triple elimination programmatic targets of greater than 90% in hepatitis B birth dose coverage. And it's important to note that as of today, only 21 out of the 57 Gavi eligible countries have introduced the birth dose. So thus, Gavi support being made available from June this year will greatly increase the number of countries who can introduce and scale up these vaccines in their countries. And specifically, Gavi will be providing like support to countries, which includes catalytic support for the introduction of the vaccines administered at birth, support for learning activities to inform and improve the program design, and also procurement of the vaccines for countries in standard vial presentations in line with Gavi's co-financing policy. And in view of this, Gavi recognizes the role that the introduction of the Hep B vaccine will provide an opportunity to strengthen integration with health services such as EPI, maternal child health services, which could facilitate better access to this vaccine. And that's why, in line with these, countries are requested or countries requesting support from Gavi to introduce the vaccine will be required to demonstrate in the applications how integration between the different programs and services will be strengthened. Like, for instance, the delivery of the vaccines should be ideally within 24 hours, which could happen either in the labor room or in the delivery room. So countries will have to show how maternity services will be strengthened or be enabled will be strengthened to be able to deliver the vaccine on time. In addition, while developing Gavi funding applications, countries will be required to involve all relevant stakeholders and will have to demonstrate that in the applications and demonstrate how they plan to work collaboratively to ensure effective service delivery. And in addition, at the global level, Gavi will ensure that there is synergy and complementarity in support provided by other partners, such as work done by the UNITAID and Global Fund, so to be complementary. So in a nutshell, that's what I can say about the Gavi program, and I'll be happy to take questions from the audience. Thank you.
Thanks so much, Michael. Yep.
Thank you.
That's amazing to see that it is back to the agenda. So we waited a lot. I remember 2 years ago in Geneva, at the hepatitis summit in Geneva, with people at the Geneva hub, we went to Gavi building to have a demonstration about that. So I'm so happy that it's back now. Thanks so much, Michael.
Thank you very much. Thank you. So I would like to invite now Karin Timmermans from UNITAID. And I think the question is similar. And we would like to hear what are the unique comparative advantages of UNITAID and in your contribution to PMTCT of hepatitis B and, of course, integration of triple elimination. Thank you very much. Over to you.
Thank you very much, Fumi. And first of all, thank you to the organizers for having invited UNITAID to this session. As probably many of you know, UNITAID is maybe relatively new to the issue of triple elimination or mother-to-child transmission prevention. But we are very happy and excited to be engaged. So UNITAID's, I think, probably UNITAID's main comparative advantage is our work on market shaping to help facilitate access to important products, and we then usually work with other partners, including Gavi and the Global Fund, to scale up that work. So that market shaping lens means that we are relatively focused on the specific products that would be required to achieve triple elimination. And what we see with regard to those products is that there are challenges both from the perspective of the supply side as well as on the side of uptake and demand. So on the supply side, perhaps the starkest example is the benzathine penicillin G, that injections of which can prevent congenital syphilis. But what we see there is, from a manufacturer's perspective, the margins are very low. The demand is unstable and somewhat unpredictable. There are few manufacturers, probably as a result of the previous 2 points, and all these factors combined then result in regular global supply shortages. So this is a major problem. I think there are also supply side challenges with regards to tenofovir, which in many countries is quite expensive. It's much more expensive, the single products for hepatitis B compared to the HIV combination products. And also with regard to the testing for hepatitis B, there are not as many quality assured manufacturers as we would like to see in a healthy market. So there's no dearth of challenges in a way. On the demand side or on the uptake side, I think the uptake has been limited. I think there are, on the one hand, I think integration has been mentioned. and is, in a way, is core to the concept of triple elimination. But I feel a little bit like the concept of integration makes a lot of sense, and the word of integration is very easy to say. But to actually be in a country and do it, and you know, to figure out the how-to and the nuts and bolts, that is often not so easy. Mm-hmm. And that then results to maybe the demand or the uptake being like not exactly as we would like it to be. And I think perhaps the hepatitis B bird dose that my colleague also talked about is another example of the uptake. There are still some questions around notably reaching like remote areas and maybe reaching those babies born at home. So I think everybody knows that, but those are some of the challenges. What Unitate is hoping to do, as I said earlier, we are somewhat new into this area, but what I hope many people in the audience know, we did launch a call for proposals in December last year. The call has now closed, and we are in the process of like assessing, also with the input of experts and partners, the proposals we have received, and we are going to invest in finding solutions, in trying things out, in the hope to then accelerate the uptake by Gavi, by the Global Fund, but also by those governments that have not yet been able to move forward. So I hope that that is helpful. Thank you.
Thank you very much. Before we clap for you, first I must say we're very excited. We were waiting for your last few comments about the call for the grant. I think it has taken the whole world by, it's created excitement in many of the organizations that are present in this room. And it'll be great also to hear maybe later the timelines, what do we expect and when. So maybe in our last round, we would ask you that so that we can all prepare. So thank you very much for your comments.
Some of my colleagues who are currently in the office and looking at the proposals, but thank you. I'll pass on the thanks.
Right.
That would be great. And we, Fumi and myself, decided that we really need to have Q&A session with the audience. Yeah. So if you have any questions now, please save it, because we will definitely have it. And yeah, and we'll have that. And then I guess let's go to countries who are actually doing the work in your area. So can I firstly ask Dr. Fikazu Muleta from the Ministry of Health, Ethiopia. We just want to ask, can you please share the experience of how your country has implemented PMTCT and leveraged the existing programs and commodities at the facility level in these efforts to be one of the country leading in this fight? Thank you.
Thank you very much. I would like to thank the organizers, especially Dr. Foon, for helping us just to be here. They were so challenging to come for this meeting for Ethiopian's team, but I would like to appreciate the one that you have done so far. Really, when we talk about the PMCT in Ethiopia, specifically the prevention of hepatitis, totally we are doing better, because almost we have made the strategy plan, what we call triple elimination of PMCT, HIV, syphilis as well, hepatitis B. In this case, the contribution of stakeholders was very great, as well the Ethiopian government has given the big commitment for the integration. When we say the integration, it is not only by the plan, but also by the resource integration, we call financial integration, the community integration, the stakeholders integration, as well the governance integration. These all are there, the reason why we are doing with one-stop shopping mechanism. When I say that, for instance, when we take the Gavi, Gavi is particularly supporting us on the pentavalent that we have started since 2007 for the hepatitis, including the 7 to 8 pentavalence components. At the same time, we are introducing the pilot test for birth dose since 3 years, and now we are on the way on scaling up just across the country for the prevention of hepatitis B. At the same time, we are doing best at ANC. We are testing for the 3 cases like HIV, syphilis, and hepatitis. So far, we have covered about 70% of hepatitis testing at ANC service delivery points. So the transmission of hepatitis from mother to child in our case is very improving. So these are the integration at which we are doing at there. And also the Global Fund has purchased us and integrating with the CHI, Clinton Foundation of Health, to purchase the dual testing for ANC, just to save our RT care, which is usually purchased by the Global Fund. So by this time we have introduced and we are doing with the dual testing to decrease the burden at the ANC service delivery points. So we're doing greater than 85% of ANC testing for syphilis and HIV as well, greater than 70% for hepatitis B. So we're good on that case. So the triple elimination strategy is functional and very effective by this time. So the other thing is we're doing strongly for testing and the treatment of hepatitis C. We're on good track, and my colleagues are here. We are working at the service delivery points and at these hospitals. We have tried to integrate, and the Global Fund is putting its print in purchasing the commodities for all HIV, syphilis, and hepatitis commodities. And also, the government is allocating the budget for the purchasing of testing reagents for hepatitis as well, for the commodities, for the drugs of hepatitis B and C. For those who are with HIV positive, we do have the drug from HIV in hepatitis B, whereas we are purchasing for hepatitis C dedicatively by the government treasure budget. So our integration is very visible, and we are so strong, and we are moving so forward. But for this session, you haven't raised the challenge, but actually the challenge is still we do have insufficient resource to do this just to eliminate by 2030. That's the critical challenge for us. Thank you very much.
Thank you.
Thank you very much. And we would ask the audience to hold their questions. Please note it down. We hope to have at least 15 minutes of engagement and question and answer. And we're trying not to be too long in our responses so that we can engage with the audience. So I want to invite now Dr. Chatri from Thailand. And I must say that Thailand is one of the champions, global champions, for hepatitis B PMTCT. And I know that in the past few months, there are moves towards the WHO global validation of hepatitis B PMTCT. So we're quite excited to have you with us. And maybe you would share with us some of the experiences and challenges of PMTCT in Thailand. I know you sent a slide set, and I think we can show some of those slides that may help your presentation. So can we have the next slide, please? So over to you, Dr. Chatri. Thank you very much.
Thank you.
Next slide, too.
Right. Thailand has the National AIDS Prevention and Alleviation Committee. This is indication of the policy in Thailand. We have 2 core committees for HIV, STI, and hepatitis B. Both committee, Department of Disease Control is the secretary of both committee, and Division of AIDS and STI and hepatitis We have an Office of Disease Prevention and Control, Region 1 to 12, for monitoring, evaluation, and technical assist, provincial health office and hospital. Thailand universal health coverage free of charge of HIV, syphilis, and hepatitis B. Over 1,000 hospitals can provide services for PMTCT. For family infection prevention, Thailand provides free of charge of condom, PrEP, and PEP. For condom, people can get a free for condom from PCU or sub-district health promotion hospital. And Thailand provides hepatitis B vaccination for all newborn since 1992. People can access for testing HIV include the HIV cell test, syphilis, and hepatitis free of charge for these services. For contraception, family planning, and condom are provided.
Next slide, please.
This diagram shows system professional and services delivery integration for PMTCT. For antenatal care in Thailand, first agency is provided in PCU or sub-district health promotion hospital and refer pregnant women to community or province hospital for risk assessment, ultrasound, laboratory interpretation. Thailand provides antenatal testing for HIV and syphilis, and third trimester for retesting for HIV is including in guideline for antenatal. And other treatment is linked to clinical, includes HIV testing service for children past exposure period, and universal birth dose of hepatitis B vaccine. 3-dose infant hepatitis B vaccination series is included in basic EPI in Thailand. Follow-up treatment and care of infants with HIV, congenital syphilis, and hepatitis B is linked to other professionals such as internal medicine, pediatrician. Next slide, please. Challenge in PMTCT in Thailand. For HIV, we found that stigma among pregnant women is a challenge for PMTCT. And late and irregular antenatal care for some groups, such as young pregnant women group, is a high percentage of late and irregular ANC. And for congenital syphilis, also have a problem with late and regular ANC too. And we have some problem referral system between private hospital and government hospital. And lack of experts for treatment for syphilis or other STI. And other challenge is a lack of data quality assurance. We lack of data for decision making on some diseases such as syphilis and hepatitis B. And the rate of congenital syphilis is tend to increase. For hepatitis B, treatment hepatitis B in women pregnancy is still challenging for us. And other is head big procurement because of after EPI program for give hepatitis B vaccine to all newborn, we found that prevalence in younger people is low, and head big procurement cannot procurement in some hospital is a low burden of hepatitis B. We plan to make a central procurement and provide head big for hepatitis B.
Thank you very, very much for sharing that. Thanks for sharing the very exciting experience and just noticing some of the hepatitis B challenges which we need to discuss in light of the evolution in the field. The new WHO hepatitis B guidelines, the access reports and how we can begin to use that to transform the field. So thank you very much. And I will now call on, go ahead, my co-chair to introduce the next speaker.
Thanks for me. So I would like to introduce our next speaker. Let me one second. So Ariel Fernandez from Clinton Health Access Initiative. So I guess what we have heard from international agencies, countries, and then you also as international agencies, but you have more work on the ground with countries. So I guess after hearing the challenges and the success that we have heard from Thailand and Ethiopia, I guess we would like to hear from you also again, what is the reflection of the current status of triple elimination, and then especially regarding and in the reflection of the challenges and the success that countries has had. Thank you.
Yeah.
Over to you.
Thanks so much. The mic is working. Thanks so much to the organizers for inviting Chai to be part of this very important panel discussion. I think somebody said yesterday that, one of the themes of this summit is to reinvigorate energy into the hepatitis elimination agenda. And so I think it's just really important for us to start with a recognition of the huge effort of WHO and many people in this room to update the guidance and policy that's now sort of laid the foundation for more integrated approaches to HIV, syphilis, and hepatitis, and really the reason for why we're able to have this discussion today. And for me, I'm sort of surprised we don't see that evolution of policy right behind us, because I think it's remarkable the amount of effort that's happened. In terms of the status of triple elimination and, just broader reflections of where countries are at, I think the country example shared by our colleagues from Ethiopia and Thailand really just captured very nicely the global trend we're seeing, which is, countries are starting to adopt and implement triple elimination, but implementation drastically varies between programs in country and between the regions. Karen, I think you talked about sort of the nuts and bolts of implementation. And I just want to call out that there's a poster on display here at the summit really highlighting another country example of a state in India, West Bengal, who's done some assessments of its readiness to implement triple elimination. And I think it really comprehensively captures and highlights the various factors from service delivery to health system coordination that countries are going to need to think through when implementing this agenda. And so I think the more important question is, what do we need to do to accelerate this triple elimination agenda? And Chai's experiences in supporting governments on this, I think, just showed that there are a couple of core factors that become really important as we push this agenda forward. I think, first of all, and this has been called out on the first day of the summit, government ownership is going to be critical to this agenda. The trust and the synergy this agenda requires between different programs can only be fostered when you have government at the helm and at the forefront of coordinating this agenda. I think, a second core factor was brought up by my colleague from Ethiopia. Countries are going to need funding to be able to implement this agenda. And I think there's been very clear messaging yesterday that, ultimately countries are going to need to carry the bulk of responsibility of financing their hepatitis programs by integrating a number of these services into their primary health care and UHC packages. And some countries like India are already doing this by themselves, which is great. But I think the reality is that a number of countries are going to need some catalytic donor funding to just have a leg up and get this agenda started. Some of you who were at the last hepatitis summit might remember the story of Rwanda's hepatitis C elimination journey. And Rwanda's entire hepatitis C elimination program really was catalyzed by small amounts of funding by the Global Fund that enabled starting small amounts of screening in people living with HIV. So, I'm really excited to have the updates from Gavi and Unitaid, who are coming in to support some of this catalytic funding. CHI and WHO and other partners have worked together with the Global Fund to evolve policies so that countries can include more hepatitis components and triple elimination components within their Global Fund applications. And later today, there'll be a workshop on progress towards that effort that I think hopefully many of you will attend. But I think the bottom line here is that we can't take these small catalytic funding opportunities for granted. And there's now a remarkable opportunity for countries to piece together support from Gavi, support from Unitate, and support from Global Fund to really get started and moving on this agenda. I think a third critical factor that I have to talk about is access to optimal and effective drugs and diagnostics. This was reflected on a lot yesterday, so I'll be brief here. The good news is that triple elimination commodities are becoming more affordable. CHI and partners have negotiated global access pricing for tenofovir, for the HIV dual syphilis test, for HIV self-testing, and their global access pricing for diagnostics as well. But the bad news is that we're not really seeing this global access pricing translating into pricing that countries are accessing. And so I think we're going to need a lot of intentional effort in the next coming years to close this gap. And some of this is going to require nitty-gritty work of understanding where you have high in-country distribution markups and how we can pull procurement. But I think a majority of this is just creating awareness that these global access pricing agreements exist and countries should be demanding that they get access to these benchmark pricing. I just have two more factors for me and then I'll pause, but a fourth critical factor is the need for community engagement in this agenda. It was brought up yesterday that the progress made in HIV programs really highlights the value of active involvement of affected individuals at every level. And I think I would take this one step further and say that the social capital from the HIV response harbors an immense potential that's largely untapped for the triple elimination agenda. And so considering the overlapping populations and vulnerabilities over here, this is going to require us to dismantle siloed advocacy efforts, even within our community advocacy, placing diverse community voices, especially women, at the center of this response. And then finally, I think a fifth critical factor is we have a lot of learnings that we can build off upon. The introduction and the scale up, for example, of the HIV syphilis dual RDT has really built the blueprint of how we can integrate services within the antenatal service cascade. And there's incredible data that showed, once countries started using the dual HIV syphilis RDT, how syphilis screening rates really jumped up in some of these countries. And so I'm hoping that we'll be able to draw from some of these lessons from the HIV and syphilis elimination programs as we continue to build our response to triple elimination. Overall, I'll just pause here and say these are just some of the areas that CHI has been supporting countries on in triple elimination and some of the factors that we think are going to be continuing to be critical as we implement this agenda.
Thank you very much for... And what I see emerging here in terms of the question, what is stopping us from achieving triple elimination? I'm seeing collaboration as central. We're talking about collaboration with the ministries of health, with global donors, with implementing partners, and with community. We need to be working together. So I'll call upon our last speaker, but not the least, our dear friend, Dr. Rania Tomia from US CDC, to give us a global perspective of how they can support and strengthen triple elimination. So thank you, Rania, over to you.
Yeah, good morning, everyone, and thank you for inviting me to be part of this panel. Talking about the challenges, going back and thinking that hepatitis B vaccine is the first anti-cancer vaccine that was available on the market almost 40 years ago. And yet, we only have 136 countries that have introduced the birth dose, with the majority of the countries that have not introduced the birth dose being in the African region, which, as we saw in the recently released estimates, has 63% of the hepatitis B burden globally. So I feel like this is unacceptable, that we're 40 years later with the first anti-cancer vaccine, 95% effective at preventing infection, and we're still having countries which have lagging this inequity in access to this hepatitis B birth dose to prevent mother-to-child transmission. In addition, we also have screening available and treatment, antiviral treatment available, which is becoming cheaper and cheaper every day, which hasn't been scaled up in these high-burden countries. So obviously, we're not on track to achieving triple elimination. And we haven't used the integration as much as we would like to get towards triple elimination. But before sharing some of the obstacles, as well as what CDC has been working to support countries in kind of scaling up elimination of mother-child transmission of hepatitis B, coming from the US CDC side, I just want to share also a success story, because from the US side, which kind of helps share lessons with some of the other countries. In the United States, the state of Alaska had the highest burden of hepatitis B back in the 80s. Very high burden, especially among the Alaska Native population. And they realized that they have this high burden, so they were one of the first states in the US to introduce the hepatitis B birth dose and the 3 doses of hepatitis B vaccine. And as a result of the scale up and scaling up treatment as well, now Alaska hasn't seen any case of hepatitis B in children in several years recently. So obviously some of the successes there is that noticing this high burden, having healthcare worker a commitment, and also engaging with the local communities on that was successful at achieving elimination in that state. So one of the key, I think, challenges which some of my colleagues also on this panel highlighted is country commitment and political support for hepatitis B has been quite lagging behind, especially in these high-burden countries, most notably in sub-Saharan Africa. So some of the challenges has been that sometimes during one of the global meetings, I used to hear that, oh, we don't have vertical transmission of hepatitis B in Africa, it's mainly horizontal transmission. But data was not there to really justify that. So what CDC has been doing is we've been kind of leveraging some of the HIV population-based surveys that are funded through PEPFAR, conducted through our CDC country offices in the countries, to test for hepatitis B, both among children, adults, women of reproductive age, pregnant women, and to see what's the burden of disease, to get up this evidence that you have this burden, there is a mother-child transmission happening, and you need to do something about it in terms of introducing the birth dose, scaling up screening and treatment. So we've run several surveys, but whether adding up on the HIV surveys, but also doing standalone hepatitis B mother-child pair surveys to look at these risk of mother-child transmission and highlighting to the countries that they need to do something. Now, many of these countries require financial support. So they need to show the data for the donors to fund them to introduce, let's say, the birth dose or scale up screening and treatment of pregnant women. So using this data from the Sero survey, it helps the country use that data to inform, for example, the National Immunization Technical Advisory Group to come up with a recommendation for hepatitis B birth dose introduction, and also using some of the pilot introduction for hepatitis B birth dose. Like, for example, we've worked with Ethiopia recently on a pilot hepatitis B birth dose introduction, and using this lessons from this pilot to inform nationwide introduction, looking at the costing and the cost effectiveness of introducing the birth dose and scaling it up in terms of preventing infections and disease. So this is has been a lot of the work that we've been doing in countries. And we see more and more of our colleagues within CDC who work in global HIV and syphilis who are also engaging with us. And they're seeing the importance of triple elimination and integration. But it takes also from our side to reach out to them and to educate them about that. Because they mainly work on HIV. They might not know much about why mother-child transmission of hepatitis B is important, because it leads to most of the chronic infections we see globally, especially in sub-Saharan Africa. So that's a way also of us engaging with our other CDC colleagues who work on that front. Now, in some countries, we see the birth dose is available, but it hasn't been scaled up because there are some policy which are part established in these countries which are putting kind of obstacles to scaling it up, such as limiting the birth dose to immunization program and not giving it in a delivery room. We're like letting the midwives give it, for example. Others, they don't allow the midwife or the healthcare workers to take the vaccine with them when they go to deliver a child at home and give the birth dose immediately. So these policy challenges are also important to address. And we've been working with several countries on kind of looking at these challenges and highlighting if they remove these obstacles, the birth dose coverage will go up. Now, one of the key challenges that I've noticed in many countries in sub-Saharan Africa is lack of awareness, not only among the population, but also among healthcare workers themselves, of why hepatitis, is a big problem and why it's important for, the midwives and the nurses when they see pregnant women coming for antenatal care to screen them for hepatitis B, to tell them about their test results, to refer them to care, and to give the birth dose within, as soon as possible after birth. We say within 24 hours, but even if it's like within 3 days, it's still better than nothing. So we've worked, for example, with Nigeria on educating the healthcare workers. And we've noticed after an evaluation before and after, the birth dose coverage, timely birth dose, increased by over 150% after the scale up in awareness among healthcare workers, awareness among pregnant women, and also linking, the community, like local community healthcare workers with the healthcare workers at the health facility to kind of reach out to the women who deliver at home so that they can also get the birth dose on time. Now, while vaccination for hepatitis B is quite, the key to prevention of mother-child transmission, but also we shouldn't forget also the mother, and also that the birth dose vaccine, it is 95% effective, but there's still a 5% risk of transmission if the mother has really very high viral load. So that's why we need to add on the screening for hepatitis B among pregnant women, as well as the providing the antiviral treatment, especially for those who are at higher risk.
Thank you very much.
So one of the challenges, I'm going to wrap up, yes? So one of the challenges has been, just my colleague mentioned, the dual test for HIV and syphilis is available. We don't have a triple test. So I think there's more need for investment and research and development to have a triple test for, as well, or maybe a quadruple test, including hepatitis C as well. So that's where one of the areas. Treatment with antivirals is available for women who have HIV, but it's not available for women who do not have HIV. So for equity purposes, supporting donor support for providing treatment also for women who are mono-infected with hepatitis B is also important. And finally, I want to finish my speech by saying that, integration will remain kind of a word without action if we don't take the first step of reaching out to our partners who work in immunization, in maternal child health, and in other programs to kind of get towards integration. It's not only HIV and syphilis, but also it's the immunization and the maternal child health program, because they're the one implementing these services. So without that as a first step, this will not be achieved. Thank you.
Thank you very much. It is evident that even the panelists are excited with this topic of PMTCT. We thank you for your comments and contributions. And yes, there's a lot of work to be done. There are new guidelines to be implemented, and I know that in the next session, we'll hear about the hepatitis B guidelines and the opportunities to advance hepatitis B PMTCT. I must say that we are at time, but I do know we started 15 minutes late, and I'm hoping that you would allow us to take 10 minutes from the break to have an engaged discussion and comments from the audience. And if I have that permission, okay, so can we have comments, questions to the panelists, or maybe some experiences? And I see many hands. I see that hand. We'll take 3 questions first, and then to the panel with brief responses. Please make the comments short and brief.
Thanks,
Please go
thanks
ahead.
Fumi. Margaret
Yes.
Hallard from the Burnett. Thanks to all the panellists. I just want to make a quick kind of comment to then ask them to respond. My sense with hepatitis B is we're going for the perfect rather than the good all of the time. Comment was made about we can actually not have to give it immediately at birth. It's the best time to do it, but you could give it a couple of days later, but that's rarely told. Also, it can be taken out of the cold chain, and I would really, I mean, Garvey has done a lot of work on this, that actually if you take hepatitis B vaccine out of the cold chain to get it to a midwife in the village, where in Africa in particular, there's a significant proportion of births in the countryside. With treatment, we've wanted to have perfect testing as opposed to getting people on treatment. So I really just want to ask the panel, how do we change what I'd say is this perspective to say stop looking for the perfect circumstance in the perfect place and just get the vaccine out there, just get the treatments out there. The guidelines have changed, but how do we get that to actually happen practically?
Thank you very much. Fantastic question. I see a second, okay, the second person, please go ahead. We'll take all the questions and then all the panel members will give some feedback.
Hi.
Can I also remind people joining online, if you have questions, please put through. I have iPad in front of me, so if you put through, I can read that out. Thank you.
Mine is not a question, but a compliment. I want to thank you, the panelists, because I am a girl living with HIV and hepatitis, and I can see your work is working because I have a daughter who is negative. I've passed through PMTCT, and much applause to you because you are doing great work. Thank you.
Thank you very much.
Thank you very much. I'm called Bambal Arafat. I work with Great Lakes Peace Center. It's a youth-led organization. I've been intrigued by the statistics which were shared here, particularly a person from Africa. We are getting about 770,000 new infections. And recently, the statistics are showing that 63% are young people living in Africa. So if you did the math, the young people are the bulk of this infection. So my just humble question is, as the panel there, what are we going to do to include the young trees? And I want to quote, there's a person who said, if you want to keep a garden of bananas, you have to get the young suckers on board. And recently I was very excited when I saw Unit 8 bring out a proposal. But somehow, somewhere, some of us in the civil society, we struggle to put the proposal, and we are not, we are not getting into the standards of the proposal. So that's my humble question. Thank you very much.
Thank you very much. We'll take one more question before we come back to the panelists.
Good morning. I am Professor Diallo from Guinea-Conakry. I have now about 6 patients, hepatitis B and C in Guinea. But I have a problem. Women who take hormone, estroprogestative hormone, have a problem, gastrointestinal problem, and treatment about viral hepatitis B and C. It's a big problem. Estroprogestative hormone. It's a big problem in my country. It's a big problem for elimination. I don't know if you have experience about it. You know what is estroprogestative? Women take for no children.
Right.
Here, intradermic or intrauterine.
Okay.
It's a big problem in my country. I don't know if you have experience about it. Thank you.
All right. Thank you very much.
And I would also like to read out the questions, a couple of questions that we received online. One thing on comment, I think, from Igor, and mentioned that when we talk about integration, who should take the initiative? Primary health care, mother and child health, or specialized services? I think, yeah, we have some idea, but then we can also talk about that. And then there's a question specifically for Dr. Michael. You mentioned several times the idea of strengthening maternity and child health services, but sometimes integration of birth dose immunization is perceived as a risk for already barely functioning services. How to reassure our colleagues and indeed reinforce existing services without increasing the burden of our already busy and tired colleagues? I think this one should be for everyone as well, if anyone want to answer.
Yes, and I would advise that the panelists focus on PMTCT. The youths are very important, children are very important, and I must say that after the session, we can all engage with the panelists for specific questions. But for the topic right now is PMTCT, and there were many questions, many comments, and I think we can allow the panel members 1 minute each to sort of articulate a response and give their last comments so that we can close out. So maybe I'll hand over to Gabi for the first 1 minute, please.
All right. Just to comment, like, broadly on the question, especially from the first question that we had on, like, trying to do the ideal instead of just getting it out there. I guess at this stage, with the support Gavi is trying to give is to, like, get the vaccines out there or get the programs rolling. Definitely as service delivery continues and as systems are strengthened, the time frame or the timeliness of administering the vaccine could be improved, but I guess at this stage it's more about getting the vaccines there, be it those born in health facility or born out of the health facility. So at this stage we're just trying to give that push to get the vaccines in country and for the population to start benefiting from it while trying to improve service delivery downstream. All right, thank you.
Thank you very much.
Yeah. Thank you. I guess I'm the next person, so I will focus on the comment/question that was quite specific to Unitate. I just want to really reassure everybody in the room that working with communities, community engagement is a very important part of Unitate's strategy, and we are very serious about that. I hear you that it may be complex for community organizations to submit proposals to Unitate and to get through the process. But the first reassurance I think that I would want to give is that every proposal that will get through, that we will fund, we are very, very careful to make sure that there is community involvement and that it isn't just a token involvement, but that it is real. And in fact, later we have a session where we will share some examples of how we are trying to do this. The other part I want to say is perhaps some of you were in the room yesterday, it came up as well. At that point, Dr. Avavia, our Deputy Executive Director, was here. He responded, and I know that he is very, very serious about that he will take this issue back to the board for a discussion with the board to see if there is anything else or additional that we can do and that we want to do. And maybe the last reassurance, but an important one, is that ultimately all funding decisions in Unitate are not made by the Secretariat. They are made by our executive board, and our board is relatively small. It has 11 members, and that includes 2 members representing civil society, communities and NGOs. So also through them, we think that communities have a big voice in the type of work that Unitate is ultimately going to support, whether it's in triple elimination or in any other area, actually. I hope that that's helpful.
Thank you very much. Thank you. So maybe from the countries, 1 minute, please. In response to any of the questions, only 1 minute, please.
Excellent. Thank you very much. Just I want to respond over the engagement of the youngers over the prevention of hepatitis. Really, in Ethiopian perspective, we directly adopt the HIV program into the hepatitis, nothing else. So our priority is the youngers, those who are sexually active, and also those who have no awareness as well, those who have no a very huge engagement with this unprotected sexual intercourse. So in that case, our client, our policy is just client-oriented. I mean, it is differentiated service delivery system is there within the hepatitis also. So we are engaging the youngers just to participate within the advocacy, the awareness creation, as well to prevent themselves, so that our priority population is the younger groups. So that's the issue, what we had in the Ethiopian experience. Thank you very much.
Thank you very much. Dr. Chatri, 1 minute, please.
Thank you. I think the important thing for PMDCT, for my view, is population-based care. I think differential services for each group of population is the key. And another key is data for decision making. If you have a data, you can making in the writing for the policy. Thank you.
Thank you very much. Oriel, 1 minute, please.
Yeah, thanks. I mean, I think there was a great question from Margaret about how we move from, the perfect policy to just practical implementation. And, I think my perspective there is we just need more country implementation and demonstration experiences, and particularly in the areas of the triple elimination agenda that are lagging behind. So hepatitis B birth dose. And so, to Gavi and Unitate and any other donors in the room, I think we're really looking to you to bring in some more funding for demonstration experiences here. And then finally, I think you mentioned this at the end of my remarks. I think coordination across a wide range of stakeholders is going to be extremely important here. And so, I'm hoping that our goal for the next hepatitis summit is that we do have not just all of us, but more of our colleagues from HIV, immunization, MNCH in the room with us, because we need to be talking about this together.
Thank you very much. Dr. Rania,
I can't agree more with Ariel. I think that's what I've noticed and that's what I've seen. I mean, it starts with us to bring the others to work, with us towards integration, triple elimination. We cannot wait for the others to bring us over. We have to reach out to them. This is what I've been doing even within CDC, reaching out, I work with my immunization counterparts, working with the global HIV program, trying to see how within our own agency we can work together globally to achieve triple elimination. So it starts with us as well, and bringing more people from other sectors, attending these kind of conferences to hear and see and brainstorm how we can integrate and work together more. And going to Margaret's comment, I think there's a lot of evidence out there from the Western Pacific region of successful interventions that could scale up timely hepatitis B birth dose, especially for home birth, and these should be implemented in the African region. Starting at a small scale as a proof of concept, we did this one part in Nigeria. I think we need to scale this further, using the outside the cold chain and testing its implementation in sub-Saharan Africa. They have experience with the MNA vaccination campaigns, but how can we work with the routine vaccine as Hep B birth dose? So we need to do more of that to learn more of what's going to work within each context. And we also have cultural barriers, so understanding some of the cultural barriers in some countries and how we can work with the communities to address that is very also important.
Thank you very much. I think on behalf of everyone, we can give our panelists a round of applause. And the key word I'm taking away is that it's up to all of us in the room. It's up to us in this room to take the message out there for collaborations, for community, for countries and everyone. I'm going to hand over to Leanne to close us up.
Yeah. Thank you very much for me. Thanks a lot to all the panelists. So there's actually
no more questions.
We are still having questions coming in, and I know that you here in the room also still have questions, but we will make sure that you have some break. So please feel free to use the app to reach out to each and all the panelists. You can reach out with them in there. And then I guess the last thing that I want to say that as someone living with hepatitis B and having daughters who are hepatitis B negative, then I guess so the kind of support that we have been talking here, that's around system support from the government, from international agencies. But I think there's one message that I want to give as well, that we also as women, we need support from the family, from the community that we are in. So all the dads, all the grandmas, all the siblings in the house, please also come in with the moms to make that happen from the community as well.
Thanks you very much.
Thank you.
Thanks
so much to the panelists.